Hi, good morning, everyone, and thank you for joining us for this very important webinar on Medicaid and Medicare. We're really happy that you are all able to join us this morning. We have a really large group, so welcome. And again, thank you for joining us. Before we get started, I do have a couple of housekeeping items I want to go over with everyone. If you have any questions, please put them in the Q&A box at the bottom, and then Bill will answer those questions at the end. And we will try and get to as many as we can. Hopefully we'll get through all of them. So please put your questions in the Q&A box as we go along, and we will get to those at the end. As a reminder, this webinar will be recorded and put on our website, so you can always go back to it at your convenience to rewatch it, and we hope you do. Also, I will send out a set of slides later today, so watch for those in your inbox. And I also wanted to mention that next Thursday, we have another webinar that we are hosting here at Achieva Family Trust. It's next Thursday, April 7th at 10 a.m. It's on supported decision-making, and our presenters that day are Nancy Murray, who's the president of the ARC of Greater Pittsburgh, and Kelly Darr, the legal director of Disability Rights Pennsylvania. So right now, I'd like to introduce our speaker, Bill McKendree. Bill is the program manager and co-founder of the Pennsylvania Healthcare Benefit Support program. It's an organization dedicated to helping seniors and those with disabilities navigate the complexities of Medicare. We are really fortunate to have Bill as a friend of Achieva Family Trust. He works a lot with us, and a lot of times we send him our most difficult questions and cases. So we're very fortunate that he is a friend of Achieva Family Trust. He has over 20 years of experience in healthcare benefits counseling, so we certainly do talk to him a lot. So at this point, I'd like to turn it over to Bill and go ahead and get started.
Thank you, Patty. And thank all you guys for tuning in, giving up a chunk of your morning. Hopefully you'll find this educational and perhaps even a bit entertaining. As an aside, if we don't get to your question, or if you think up questions that we don't get a chance to cover today, at the bottom of this intro slide is my telephone number, and more important, my email address. If you shoot me an email within about 24 hours or so, I will strive to get back to you and make an initial contact so that we can either in that contact discuss the question and hopefully answer it, or at least set up an appointment that we can move forward. Also, if you would like to visit our website, you can use the initials phbsp.org. If you Google that, it'll take you pretty much straight to our website, and you can check us out and all the stuff that we do. So let's get started. The premise of today's presentation is based on the idea that currently around 10 million people in the United States are eligible for both Medicare and Medicaid benefits. And that number is going to grow. It's going to grow as more and more individuals that are already in Medicaid are going to age into the Medicare system, or individuals that are already in Medicare are going to intersect with Medicaid because of the necessity of institutional care in long-term care facilities, or utilizing the Pennsylvania Waiver program for care being delivered at home for personal care for individuals who cannot perform the activities of daily living. In either case, whether it's Medicaid going into Medicare or Medicare going into Medicaid, that confluence of those two benefits adds what's even already significant difficulty in understanding how it functions and how to utilize it to effectively access your healthcare, your prescription medications. It muddies it up even more. And so getting a sense of the functionality of these two, not just independently, but as they work together, at least having a basic concept, I think is essential to be able to effectively understand what's working, how it's working, and to make certain choices within the context, those kind of things you have some control over. So we're going to look at essentially how Medicare works. I'm going to spend most of the time looking at the Medicare and simply assume if the patient is eligible and transitioning into Medicaid or already in Medicaid, and not go into detail for the various ways that an individual is eligible for Medicaid. But I am going to look at when those two things finally intersect, when an individual is now in both Medicare and Medicaid. It's called dual eligibility, and how that functions, and the unique characteristics of Medicaid for a large number of individuals in Pennsylvania under the Community Health Choices program, which has been the process by which we have shifted the Medicaid system to a privatization using private insurance companies, now called MCOs, to deliver access to the care and cover the costs abrogated by the state down to these private entities. So let's start with basic concepts of Medicare. The Medicare system has been around now for almost 60 years. And its initial premise was to create a platform where certain qualified individuals would be able to access a basic healthcare guarantee. It was created back in the mid-1960s to assure that those individuals because of their age or disability, would be guaranteed at least a fundamental healthcare platform guarantee. And for a while, it was presumed that singularly Medicare itself, the basic government components, would be sufficient. Within a decade or so, that changed, and what occurred was an incorporation of both a hybrid of Medicare as a government program and the private insurance products that swirl around Medicare. We're going to look at that. Just to get your head around Medicare itself is an achievement. So understand that it's a federal program. It was created in 1965. It went into effect the beginning of 1966. It represents over 60 million individuals in the United States. It is, in combination with Medicaid, the largest healthcare system in America. It's currently administered by an agency of the federal government, the Centers for Medicare and Medicaid Services, which is under the Department of Health and Human Services. Although entry into Medicare, enrollment into the basic Medicare platform is done through the Social Security Administration, or if an individual has worked under the railroad retirement system, rather than Social Security, they would do it through the Railroad Retirement Board. Although inevitably, even the Railroad Retirement Board is going to pass on the enrolling process ultimately to the Social Security Administration and then into the Medicare system. So when I say Social Security, I could also be meaning the Railroad Retirement Board, if that's more applicable to the individual. So just for simplicity. The reason Social Security was tapped to do this was because back in the day, the eligibility for Medicare was age-based, and it coincided with the same age that individuals would go into the Social Security Administration benefit system. So it was felt just for efficiency and cost effectiveness to let the Social Security Administration carry the load for both enrollment processes. As we've started to split the eligibility criteria, 65 still with Medicare, but aging up for Social Security, it's not as absolute that individuals will be sitting down with Social Security to accomplish both things as they're turning 65. In fact, many individuals are even postponing entering Medicare till past 65 because they're working past 65. But nevertheless, still, Social Security is the go-to entity for the individuals that are going to ultimately enroll in the government platform portions of Medicare, the Part A and the Part B. Fundamental characteristics of Medicare: it's a fee-for-service program. And that means when you go to a healthcare provider, doctor, hospital, clinic, and that doctor or hospital or clinic accepts Medicare, there is the presumption that the portion that Medicare is covering will be directly represented between the provider in the Medicare system. You will not have to pay and seek to be reimbursed, but there will be some cost sharing. Part of the services that are going to be provided by the individual that recognizes Medicare is likely not going to be fully covered by Medicare. There's going to be some cost sharing, some co-payments or co-insurance or deductible that has to be met. The other thing about utilizing Medicare, unlike utilizing an HMO, a health maintenance organization, or a PPO, a preferred provider organization, which most people are typically used to if they're employed and covered by some type of employer coverage, or if they have private insurance. Unlike those, if you are covered by Medicare and that is your primary coverage, meaning Part A and Part B of Medicare is your primary coverage, you have the ability to go to any doctor, any hospital, any care provider anywhere in America with a stipulation, do they accept the Medicare card? And every hospital that you can imagine going to is going to accept the Medicare card. To be licensed in their state, to receive federal funding, those hospitals must take Medicare, and they will take Medicare. And more than 97% of treating physicians and practices in America also work with the Medicare system. So very likely any doctor or clinic, any practice that you would want to go to, or certainly the hospitals that you would go to, will accept Medicare. And thus you have access to the entire American healthcare system, unlike worrying about, does my HMO or PPO get accepted by this particular doctor? Is this particular healthcare provider in my network? There is no network other than, do the providers work with Medicare, which invariably they most likely will. So individuals enter Medicare based on one of three criteria. By far, the largest number of individuals in the Medicare system are there because they've aged into the system. They're 65 years or older. If you are a US citizen or permanent legal resident of the United States, turning 65 is the only criteria. Welcome to the club. Not saying it's free, but welcome to the club. About 25% of the people that are in Medicare in any given year are under 65. They're there either because they've been recognized as disabled by the Social Security Administration or railroad retirement, or they've been recognized as end-stage renal. They're at the final stage of their kidneys no longer functioning. And as a result, they're either looking at dialysis or a kidney transplant. Now, if the individual is eligible based on disability, first, they've applied to the Social Security Administration to be recognized as disabled. Once they're recognized as disabled, disability benefits begin, usually about 5 to 6 months after the definition of their disability has been determined. After the first benefit is paid, a 24-month clock starts ticking. And within those 24 months, the individual is still not eligible yet for Medicare, but once the 25th month is reached, they're automatically entered into the Medicare system. There's an exception to that. If the individual has been recognized as disabled, and that disability is amyotrophic lateral sclerosis, Lou Gehrig's disease, then the 24 months is waived. So in that case, the individual applies, is recognized as disabled. There's about a 5 to 6 month wait to get their first monthly benefit. Once the first monthly benefit is deemed eligible, they're automatically eligible then for Medicare. Reason being, to make an individual with progressive ALS to wait 24 months is likely going to be minimal utilization because they're not going to last much longer than the 24 months, or at least when this was introduced as an exception, it was pretty much foregone that the individual would not make it to the 24 months or barely make it. With end-stage renal, it's also because this is not determining that you're disabled. We're not waiting for disability determination or the beginning of disability benefits. Once the Social Security Administration has recognized you as end-stage renal, you're automatically eligible to enter Medicare. So either age or disability, plus some waiting time for most individuals, or a determination of end-stage renal is the entree point for the basic platform of Medicare, Medicare Part A and Part B. And that's the other thing about the Medicare system. It's made up of components, a lot of them. Didn't start that way. Once upon a time, it was imagined that Medicare itself, the Part A and Part B of Medicare, would be enough. What it was imagined in the mid-1960s, it was imagined as an alternative to having to pick up private insurance, because back in those days, private insurance wouldn't sell to individuals that were old enough to be in Medicare or disabled to be in Medicare, or what they sold them wasn't very good or just was too expensive. As the utilization of Medicare continued into the second, certainly the third decade, and the costs of the care escalated significantly, it became apparent that Medicare alone, Part A, Part B, wouldn't be sufficient. So we were at a crossroads. We were at a crossroads pretty early in Medicare's introduction, that either the government would increase the percentage that Medicare itself would cover. It covers about 80%. And the 20% back in the day, as a real dollar amount, was small enough that most individuals could afford to pick up the cost. Certainly by the late 1970s, early 80s, 20% of the cost in real dollars was often beyond what most individuals, most families could afford. And so Medicare could have chosen, the government could have chosen, to increase the percentage, to make it 90, 95%, or just cover the entire cost. But they didn't. What they did instead was aggressively seek to bring, ironically, private insurance into the mix, the same entity for which Medicare was originally created, because they wouldn't cover individuals independently. So what we have is this hybrid of government and private enterprise. And honestly, what we have is a constant shift to the premise that more and more of the responsibility would be taken by private enterprise, by private insurance companies, for better or for worse. And that's what we have now in Medicare. This system that's made up of a fundamental basis that represents the government's portion of healthcare coverage, Medicare Part A and Part B, and complemented with private insurance products that pick up some additional costs that Medicare A and B doesn't. So Part A has been, likely always will, responsible for a significant part of the cost represented for inpatient services, being in a hospital, being in a rehab facility. Part A is probably the more comprehensive of the two. In fact, it really represents a bit more than even 80%. It was intended that way because back when it was created, it was the idea that being in hospital was going to be the most expensive premise. And back then, people would be in hospital for a lot longer period than they would now. Typically, where the significant costs of care, the burdens to families for receiving that care would be under inpatient services. And thus, Part A was seen as an essential component. Part B, ironically, was almost considered elective, that as long as the individual had at least Part A, they were looking pretty good. But within the first couple decades, there was a shift from reliance on inpatient services, inpatient facilities, to more and more outpatient. Now, Part B literally covers 80% of the cost. And as more and more of services became outpatient and more of these services escalated significantly in cost, 20% the part that the patient had to bear, became in real dollars unacceptable for most individuals. But that's what you have now. A foundational reliance on Part A, which covers a significant part of inpatient costs. Part B, which covers significant, not quite as much, of outpatient services. And this is often referred to, Part A and Part B, as traditional or original Medicare. And again, for a while, for a decade or so, that was it. This is what individuals would have, and it worked adequately. But not anymore. More and more private insurance is being utilized to pick up the slack that A and B don't. Now, costs for having Part A, because it was deemed to be essential, because it was the core part of Medicare from the beginning, it's likely going to be a zero premium. And the reason it's going to be a zero premium is the individual, while they are working prior to their going into the Medicare system, are paying into the Part A portion of Medicare through their earnings. Out of their earnings comes a certain portion, usually about 8% and some, and matched by the employer so that it combines to about 3% of that individual's paycheck. Over the course of their working lifetime, each year, they're accumulating credits towards their Part A premium. Imagine each year is 4 quarters. So for each year, you're getting 4 credits towards the desired maximum of 40 credit quarters. And so essentially, if you're working at least 10 years, doesn't have to be 10 consecutive years, but as long as you've put that length of time in the workplace, you can expect that you've achieved the requisite so that your Part A has a zero premium for the rest of your life. You can piggyback on a family member so that an individual who hasn't themselves accumulated the 40 quarters can rely on a spouse who has accumulated those 40 quarters, and through that. And there's a staggering of those quarters for individuals that are entering the Medicare system based on disability at a much earlier age. So the 40 quarters is fairly requisite for individuals aging into Medicare, but that can often be bypassed if the individual is going in at an earlier age based on disability, or if individuals do not have the requisite quarters based on their age, based on their circumstances, and don't have a spouse that they can piggyback on, then often the state, in this case Pennsylvania, will pick up that monthly premium for Medicare Part A based on meeting certain criteria. If not, then the cost of just having Part A. So if you have not worked long enough, do not have a family member you can piggyback on, and do not meet the criteria for the state to pay for your Medicare Part A premium, you may find that you're paying nearly $500 a month just for Part A. And there are a number of ways to work around it. Most of the time, most individuals are going to meet the criteria one way or another, that this is not going to be a particular issue. But if that does arise, our program is utilized to help those individuals bypass that problem of coming up with the $274 or the $499 if they don't have the requisite quarters. Part B, on the other hand, is always going to have a premium. So when an individual fully enters Medicare, picks up not just the Part A, but also the Part B, they should expect that each month their Part B is going to have a requisite premium. Now, currently, for 2022, the base premium for Medicare Part B per person is $170.10 a month. Some individuals are going to pay more than that. They're going to pay in addition to the $170.10 a month, an income-related Medicare adjustment amount, an IRMA. The IRMA could be as low as $68 or all the way up to $408, depending on the size of the individual and if they have a spouse and they file a joint tax return, their combined income. And that's regardless of whether the spouse is eligible for Medicare or not. If they file a joint return, the joint return income is going to be looked at. So an individual, as an individual, if they're below $91,000 for the annual tax information, or if they file a joint return, if they're below 182,000, simply combining the 91,000, doubling it, they're going to pay the base amount. If they're above that amount, they're going to pay some additional IRMA, which could create a premium requirement for them as low as $238.10, all the way up to $578.30. One other thing about this, well, two other things about this. First of all, Medicare doesn't look at your current income situation. Their position is if you're entering Medicare, and everybody's going to enter Medicare at some different point in the year based on when they turn 65 or when they're past 65, when they're no longer working, to determine what that income is for that year is unpredictable, and to Medicare's position is irrelevant. Why even go to the trouble of trying to make that determination? So the way they make their determinant for that initial year is to look 2 years back at the individual and the tax information they had. So if an individual is going into Medicare in 2022, Medicare doesn't look at where they are now in 2022. They go back 2 years to 2020 and look at their tax information for 2020. What tax information? Their federal tax return. Or if they didn't file a federal tax return, that information that would be used to declare what incomes this individual received or this family received. So the W-2s, the 1099s, but most invariably, they're going to be looking for a tax return, a 1040 for 2020. They're going to look at the modified adjusted gross income on that tax return, and they're going to determine whether it's above or below whatever number. And based on that is going to be for that particular year, 2022, a determination of what their Medicare Part B premium is. Now, it's going to change every year because in 2023, they're going to look back 2 years to 2021. And 2027, they'll look back to 2025. There's always going to be a 2-year delay, and it's always going to be progressive. And here's the second point. If you can demonstrate to the Medicare system that your current year's situation is likely going to be significantly different, the premise being significantly lower than the 2 year ago situation, you can ask for a redetermination. And again, one of the things our office does on a regular basis is assist the individual in preparing a request for redetermination so they can get their Medicare Part B premium reduced to the base amount, eliminating the IRMA, at least for that particular year. And it's an ongoing thing. It's like a pig working through a boa constrictor. Every year, 2 years ago is going to be a determinant. So what happens now, 2 years from now, is going to be reflective in how you're going to be measured for your Medicare Part B premium. Individuals entering Medicare, if they're doing it when they're turning basic eligibility 65, are doing it in a 3-month ramp-up period. So if I'm turning 65, let's say in April, then my 3 months of ramping up would be January, February, and March. And if I've reached out to the Social Security Administration system in those 3 lead-up months, the 3 pink months, January, February, March in this scenario. Then on the first day of the month that I turned 65, the first day of April, I would enter the Medicare system Part A and Part B. If my birthday just happened to be the first day of April, I would actually get to enter 1 month earlier. So my entry point, my golden column would be March in that case, and the count back 3 would be February, January, and December. So, but normally, typically, the month that you're born in, the first day of that month is your first entry into Medicare that month that you turn 65. You can still reach out in the month you turn 65 and 3 months even after that. But if you reach out in the 4th month, the month you turn 65, or the 3 months thereafter, there's certainly going to be a delay of entry. So just know that. The optimum time, if you anticipate going in when you can most earliest go in, would be in the 3 leading up months. And usually in the 3rd or 2nd month before your birth month is the optimum time to reach out to the Social Security Administration. Well, if this were not pandemic time still, I would have said you can walk into the Social Security office and take about an hour's time of your life and be enrolled. Local offices aren't taking walk-ins still. And honestly, it's a lot easier, a lot more efficient to simply enroll for Medicare Part A and Part B online by going to ssa.gov. But however you do it, anticipate giving yourself enough time to complete the application, have the application process, to be notified that it's been effectively produced and you're now enrolled in the Medicare A and B, and enough time to pick the additional products that you're going to use to enhance Medicare A and B. Some people delay entering Medicare, as I said before. They're delaying because they're either working themselves or there's a spouse that's still employed. And as long as the individual or their spouse is actively employed, and through their active employment, they're covered by an employer group health insurance. And warning, that should be a large employer. Large employer is defined in this case as 20 or more employees. Less than 20, there are some problems, some significant dangerous problems with the utilization of private insurance, even an employer group product. So caveat to this exception is certainly accessible for individuals that are employed or through their spouse's employment, but that employment really should be through a large employer to make this effective. If that's the case, an individual can delay entering Medicare indefinitely, as long as they're continuing to work and covered by the employer plan, or their spouse is continuing to work and covered by the employer plan. They can postpone entering Medicare Part A and Part B, or at least the Part B portion. And in those regards, there's not going to be a penalty or a delay down the road when they attempt to enter Medicare once their exception is terminated. And there is a process for doing it. Another story for another day. And again, this is something that our office does, is help individuals navigate into Medicare after they've delayed enrolling until they've terminated their employment. Now they're past 65 years old. In any case, whether you're entering based on turning 65, whether you've delayed entering because you were working, whether you're entering based on disability or based on end-stage renal, the ultimate process is still picking up the Part A portion of Medicare and the Part B portion of Medicare. It's your fundamental platform upon which the private insurance products are going to be added. So this is always your starting point. If we're looking at the first baby step, it's picking up A and B. Some people may pick up A initially and postpone the B because, again, they're working or the spouse is working. But ultimately, when they're fully in Medicare, they're going to have Part A, they're going to have Part B. And because Part A and Part B are not going to be comprehensive, or certainly not comprehensive enough for most individuals in their anticipation of getting adequate coverage. Those individuals are going to be looking at deductibles and co-payments, dollar amounts that they have to meet, or co-insurance, a percentage of the cost of the services that they have to meet. Because of that, they're going to rely on private insurance. And this, again, is why you're going to give yourself 2 or 3 months to ramp into the Medicare system, not just to make sure your Part A and Part B are in place, but also to make sure that your private insurance is also in place as well, so that it's all hitting at the same time. So this is the core of the problem of Medicare. If it were as simple as you get A, you get B, it pays for everything, the end would be a simple idea, but it's not. And so the reflection and the problem is not just the Part A and Part B, which is elemental to everyone in Medicare, but what else do I get? And this is where the problem arises. So there's 3 general columns that you could be applicable. Depends on the individual, depends on the individual's circumstances. So possibly an individual is under Medicare A and B, and is also using a private insurance product that is available to them because they work for an employer that is offering a retirement benefit. People that work for public school systems, people that work for the University of Pittsburgh or CMU, people that work for government agencies may very well have access to an employer-provided retirement benefit, a post-employment benefit that they can incorporate with their Medicare A and B coverage. It's a minority of individuals in America, and certainly even in this area, but it's a significant option, and it's certainly not one to be overlooked. Some individuals, and the point of today's conversation, is those individuals are going to be also eligible for Medicaid. Those dual eligible individuals are going to coordinate Medicare A and B and the Medicaid benefits. But in Pennsylvania, the Medicaid benefits that represent the enhancement to Medicare A and B are going to be provided by private insurance called MCOs, managed care organizations, essentially an HMO type format. And the third possibility, the one that most individuals in Medicare are going to utilize. Most individuals are not going to have an employer that offers a generous retirement benefit. Still, most individuals in Medicare are not going to be dual eligible, although it's a large number. It's still not a minority of the individuals. Most individuals going into Medicare are going into Medicare with the necessity to go into the marketplace and purchase on their own some type of private insurance enhancements to Medicare A and B. So we're going to obviously look at the middle column, but I want you to understand what the nature of private insurance looks like, because one of the options that you can do within the context of being enrolled in both Medicare and Medicaid is also looking at private insurance enhancements. And understanding dual eligibility is also understanding what these private insurance enhancements look like. So if you took the entire universe of Medicare and all of the private insurance products you could buy, whether it's through what the employer provides, through what Medicaid provides, through what you go out and find on your own, it is invariably going to fit into one of these 3 categories. Everything out there that is private insurance, no matter how you get it, is going to be one of these 3 categories. It's going to be a supplement to Medicare. Medicare A and B is going to be your primary benefit coverage. When you go to a doctor or a hospital and they say, what's your coverage? You say, it's my Medicare card. Here, my red, white, and blue card, Part A, Part B, that's primary. And then they say, Well, that only covers a certain amount. How are you paying for the balance? And you show your second card. Here's my supplement. It could be a private insurance supplement called a Medigap. It could be an employer-provided supplement called a supplement, typically, or whatever fancy name they assign to it. Or it could be Medicaid. Medicaid, when an individual is dual eligible, Medicare and Medicaid, Medicaid is secondary now. It's the supplement to Medicare A and B. Instead of getting a supplement to Medicare A and B, individual gets what's called a managed care product, officially called Part C, also kind of officially called an Advantage plan under Medicare. However they're called, what they are managed care HMOs or PPOs. They don't supplement Medicare A and B. They replace Medicare A and B. Now, let me clarify this for you. You still have to be enrolled in Medicare A and B. You still have to pay whatever the premium is to have Medicare A and B, whatever that is. You just don't get to use it if you select an HMO or a PPO product. If you select a Highmark Freedom Blue PPO or a UPMC for life HMO, that's it. That's what you've got. Medicare A and B have abrogated their responsibility to pick up any part of the coverage for you at that point. It's purely on the backs of the HMO or PPO insurance company to pay for the cost of your care. And these private insurance companies have taken that responsibility, not for some altruistic reason. Certainly, remember, they're the entities that didn't want to cover individuals back in the pre-Medicare age. The reason insurance companies are now stepping up and taking this responsibility is because they are well subsidized by the Medicare system for doing this. They're not the supplement. They're not relying on Medicare to pick up still the lion's share and picking up some and charging a premium like with supplements. No, these guys are picking up the entire load. And they're doing it because the federal government subsidizes these private insurance companies to the tune somewhere between $1,000 to $1,500 a month, every month, if you select an HMO or PPO product rather than rely directly on Medicare A and B. Why? Because Medicare says, hey, we're not responsible for you any longer. That's the private insurance problem. And they've determined that that $1,500 a month that they're providing to the private insurance company is cheaper on average in general than what the government would have to pay directly to be the primary provider for you. So right now we have two possibilities. You can utilize Medicare directly and supplement it. Medicare is now on the hook for a significant part. And what Medicare would really rather see you do, to the tune of the largest expenditure that Medicare is making, is the subsidization for private insurance. And in that case, you're now lining up with a private insurance, and your premium to them is minimal. One of the, let's say, strong suits of the Part C Advantage plans is their cheap premium. They can afford to be cheap. They're getting $1,500 a month from the feds in lieu of collecting directly a premium. And so they can afford to not only offer coverage that is a little bit better than what Medicare A and B would be, they can also offer certain swags to enhance the desirability to going with them. Basic dental services, basic eye care, some other kinds of things, and roll in prescription medication as part of the process and give you a concierge that will help navigate through the process, whatever it takes. And the premium's going to be cheaper than what the cost of the supplement is. You still have to have A and B, you still are paying the same amount, but rather than paying, let's say, $100 to $150 for a supplement, You can get an HMO or PPO for as little as 0 or 20 or 30 or 40. Remember, they're being subsidized. They can afford to do that as long as they're being subsidized. And so the dynamic currently is to encourage more and more and more people to turn their back on using Medicare A and B and rather use Advantage plans. Medicare is certainly squaring behind that option and certainly putting a large amount of their resources towards supplementing that, rather than utilizing the resources to spend it directly on your coverage. Now, whether the individual has a supplement and relies on Medicare A and B as their primary coverage, or abrogates that and uses an HMO or PPO, the third category of coverage they're going to invariably need is prescription drug coverage, a Part D plan. So you're going to have, if you're in Medicare, either the first category, a supplement, and a Part D plan, number 1, number 3, or you're going to have an Advantage plan, number 2, and drug coverage, number 3. And typically, in that case, the drug coverage is built in. It's attached to the Advantage plan, so that by buying an Advantage plan, you're getting automatically Part D coverage along with it. And this is what schematically these two options look like. So I have Medicare Part A and Part B. It's my primary coverage. I have a supplement. And in this case, we're using a private insurance supplement, a Medigap. And a Medigap, it's going to cost about, depending on your age, when you enter, other circumstances, somewhere in around just under $100 on the low end to about $150 or so on the higher end. If you use option 1, Medicare A and B as your primary coverage, you can go to any doctor or hospital or provider anywhere in America. You have incredible reach. If you have a Medigap, a comprehensive Medigap, a good Medigap will cover the entire balance of the cost of your care. Let me drive this point home. When you go to a doctor or hospital, a care provider anywhere in America, and you say, you guys take Medicare, right? Yep. Well, here's my Medicare card and here's my Medigap. And the cost to you after Medicare A and B and the Medigap are done picking up the cost to you is often 0. No matter how complex or expensive those services are, no matter what those services are, if they're picked up under the Medicare system, A and B and a supplement are comprehensive. It's the closest thing you're going to get to 100% coverage in the Medicare system without using Medicaid. You'll still need to get a Part D plan. There's the rub. The weakest link in this process, whether it's option 1 or option 2, is prescription drug coverage. This is where often the significant costs lie. And a supplement cannot pick up the balance of prescription drugs. As far as outpatient and inpatient services, you can have comprehensive coverage for prescription meds. No private insurance company, no Part D is going to say, oh, we'll pay the entire cost of your meds. They wouldn't last very long. And you're also going to be looking for services that are not under the Medicare system, like basic dental and basic eye care. And some people are going to say, yeah, I like the idea that I can have comprehensive care, but you know what? After I'm done paying for my Medicare Part B, $170, and another 100 and something for my supplement and some premium for my Part D. And it's like, wow, that's like $300 a month. I know it can be expensive. It's on the spectrum of quality, the highest possible kind of coverage you can get. It's the closest you're going to get to total 100% coverage for your healthcare services. But some people blanch at the idea of paying that much in premiums collectively. Either they can't or they just don't want to. So option 2 represents you still have to have Medicare A and B, so you're still going to pay that $170 or whatever it is for your Part B, but you can get an HMO or a PPO very, very, very cheap. And they can roll in the eye care and the dental care and the Part D prescription drug care very, very, very cheap in terms of premium. The cost sharing, that's another story. But then again, you're seeing this in the immediate gratification of getting a cheap product and some swag thrown in there, some eye care, dental care, free health club membership, whatever is attractive to you. But keep in mind, the exchange is limitation. You go to where the network sends you. You get the services that are dictated by the network, and there will be cost sharing. Possibly some of the low-end services like a PCP visit or basic diagnostics like blood work may have zero co-payments, or certainly a small co-payment. As it progresses to more and more expensive services, high-end diagnostics, hospital stays, operations, in or outpatient, that cost sharing is not going to be small. But that's what you're buying into. That's the risk you're taking by going with option 2. So there's the fundamental functionality of the Medicare system. This is how it looks. We're going to mix it up now with Medicaid. But before I do, I want to show you one other thing. For many individuals, the cost of prescription medications is the biggest problem. As I said before, backing up. Individuals that have Medicare A and B and a supplement have the expectation they're going to pay nothing or very, very limited amounts for even the most high-end expensive services throughout the year, except for their prescription medications. Whether the Part D is a standalone under option 1 or incorporated into their HMO or PPO, they're going to be based on limitations. And because we're no longer looking at inpatient care the way we did back 50 years ago as the primary source of care and the primary cost, or even outpatient any longer, the biggest cost driver for many individuals, the majority of individuals that are in Medicare in America today, is the cost of their prescription medications. As an example, how many individuals go into hospital every day for some service? How many individuals go in for outpatient services every day? How many people take prescription medications every day? Not just 1 or 2, but a lot. The average number of prescription medications taken by an individual that is 65 years or older is more than a half dozen. By the time they reach 75, it's nearly a dozen medications a day. Now, if you take less, that means for that average, some people are taking more. And many, many individuals take way more than just a half dozen to a dozen meds. Some individuals that we've counseled exceed 2 dozen medications. Now, some of those medications probably are redundant, but nevertheless, it is not unheard of for some individuals taking combinations of medications for multiple conditions. And the problem with that is no Part D plan by itself is going to cover a significant part of those costs. There is going to be cost sharing. The likely best hope that an individual has in terms of a Part D is splitting the cost at 75-25% per medication. It might be a little bit better. Some meds might be covered at, say, 80-90%. Some might even be covered at 100%. Some generics, especially the ones that retail for less than $10, are often covered at close to 100%. But the more expensive medications are certainly not. And those medications are usually split somewhere between 70-30 to about 75-25. And that's until you hit the donut hole, the coverage gap. In the course of a year, if your medications retail exceed $4,430, and that number goes up a little bit every year. If you exceed that initial coverage limit amount, the insurance company is done with you. Their position is, we cover you up until you reach that magic number, the initial coverage limit. At that point, you're in what's called the coverage gap. And we don't pick up any cost of the medications while you're in the coverage gap until you bought your way out of the coverage gap and reaching the out-of-pocket limit, currently $7,050. So between this number and this number, individuals are compelled to, out of their own pocket, pick up the entire cost in the bad old days. Now, the good news for individuals that have no other source of assistance other than their Part D plan is the federal government will step in, regardless of your income, regardless of your circumstances. If you are in Medicare and you have a Part D plan and you've hit the donut hole, the federal government currently will step in and will continue to pay a portion of that cost of your meds while you're in the coverage gap. But you're still shelling out a significant percentage for the cost of your meds throughout the year. And if it's a 75-25 split, and the medication is not measured in dollars or even hundreds of dollars, but thousands or tens of thousands of dollars for a 30-day supply, and that's not unusual for the high-end specialty drugs and the chemo-type drugs that individuals are taking. As a result, even 25% of the cost could be staggeringly thousands of dollars a month. And individuals find that the worst economic situation for them is facing the acquisition of prescription medications that they obtain at the pharmacy under their Part D card, to which, even if they have incredibly good coverage for in and outpatient services, they're still plunking down hundreds or thousands of dollars a month to access their medications. And for individuals that are not eligible for assistance programs, this becomes the most significant burden, and the one that we deal with at our program the most, helping individuals navigate accessing their prescription medications in the most cost-effective way. Now, there's certain tools that we have available, but the most effective tool, ironically, and unfortunately for a large number of individuals, is for individuals that are low income. There are benefit programs that will pick up most, if not all, of the cost of their medications, regardless of what the Part D plan is doing. We're going to look at that as we transition into the assistance programs that work now with Medicare for individuals that are dual eligible. So what I've shown up to this point is a representation of what Medicare looks like for those that are solely individually in the Medicare system. Now, what happens for individuals that are layering on this Medicaid, or individuals that started in Medicaid and are now going into Medicare because they're aging into the Medicare system, or they've been disabled long enough under Social Security that they're now eligible for Medicare? So Medicaid, like Medicare, is a federal program. Unlike Medicare, the states have a big administrative say in the process of Medicaid in each of their states. Federal allocations are often matched with state allocations. Again, unlike the Medicare system, which is exclusively a federally funded system. And each state has a slightly different approach. Now, there's certain common characteristics that must be applicable if the state wants to get federal funding for its programs, but there's some variation. So I'm going to be mentioning particularly Pennsylvania as it applies, but pretty much the surrounding states, or any of the states you would be thinking of, are going to look very much like this. There are numerous ways individuals can be eligible for Medicaid. And for our conversation, it presumes that the individual has met one of these criteria. They're in Medicaid because their economics are so low. They're so impoverished that they're below the federal poverty level, and thus they're in Medicaid because of that. And usually those individuals have been in Medicaid before they age into or disable into the Medicare system. But for some individuals that are disabled and income and asset meet the criteria, they can be eligible through a program called Medical Assistance for Workers with Disability, the MOD program. And actually, let me tell you, the MOD program can be quite a game changer for individuals. Rather than having to be economically distressed below 100% of poverty, Individuals can have as much as 250% of poverty. And for an individual, that could be nearly $3,000 a month and be eligible for full Medicaid. They have to be recognized as disabled. They have to be under 65 years old. And they have to have minimal assets. And they also have to be working. Working in this case is minimal, an hour or so a week. Theoretically, it could be less than that, but you want to show continuity, an hour or so a week. Any kind of activity that has a presumption of receiving compensation for it, and that could be even for family members, as long as you're not living with the family member. Suddenly, individuals that would not have met Medicaid through any other circumstance are in Medicaid through the MOD program. But some individuals are in Medicaid because they're also collecting SSI, Supplemental Security Income. And probably applicable for a number of you guys that are listening in, they're in Medicaid because they're receiving assistance for their personal care at home through the state's Waiver program, or the individual is institutionalized in a long-term care facility and they need the state of Pennsylvania to help them with the cost of being there, thus Medicaid. Regardless of the reason why you're in Medicaid, in these circumstances, you are now going to be considered a dual eligible if you're also in Medicare or when you become eligible for Medicare. And in any of these cases, it's understanding how to coordinate the Medicare system with the Medicaid system. These individuals are referred to as dual eligibles. And invariably, Medicare is primary, Medicaid is secondary. If the individual was in Medicaid earlier, if they're aging into Medicare or disabling into Medicare, they were used to Medicaid being singularly their benefit. And now that changes instantaneously, automatically. Once they become a dual eligible, once Medicare kicks in, Medicaid automatically drops to a secondary benefit. Surprise. And they might not be prepared for it. No one might tell them that this is what's going to happen. That once Medicare is now in effect, that the Medicaid is not the singular benefit, that their Medicaid card is not going to work in the same way. And that's not necessarily problematic because even if they don't fully understand what happened, the effect of it is functional. It is going to go into effect regardless. And the providers of services are ultimately going to figure out that they're not going to get all of their reimbursement from the Medicaid system. They're going to get it from the Medicare system, and the balance of what Medicare A and B doesn't pick up will be picked up by the Medicaid. One area where it becomes problematic, the one transition goof, is when they were just Medicaid, Medicaid paid for their prescription medications at the pharmacy. Did a perfectly good job. And now they've transitioned from reliance on Medicaid paying for their prescription medications to Medicare. And by that, I mean Part D. Now you're thinking, oh no, this is going to be devastating. Not necessarily, because there's another benefit that's going to also come into play for individuals that are Medicaid eligible. I'm going to talk about that in a minute. But it does require the individual has Part D coverage. And this is often where a goof happens. The transition from being purely Medicaid to now a combination of Medicare and Medicaid, and the necessity to have picked up a Part D plan manifests itself in a problem during that first month or two when the patient or the patient's family shows up at the pharmacy to pick up their meds, pulls out their Medicaid card and says, here, put it on this card. And the pharmacist says, sorry, the card doesn't work anymore. Why? Because they've transitioned. And that transition means they need Medicare to represent the coverage for their drugs, which means Part D to represent the coverage for their drugs. Only they didn't get Part D because they didn't know they had to get Part D. And so we have this first month or so, or the first time they're picking up their meds, where there's a problem. Now there's a workaround for that. And again, one of the things our office does is work with the pharmacy to utilize a program called LINET, L-I-N-E-T, to act as a temporary surrogate. What we're finding is, fortunately, the feds are getting a little more efficient in making this transition for the individual patients effectively aware of the necessity and helping them secure the Part D plan well before the transition in. But every so often, somebody falls through the cracks and we utilize LINET as a temporary Part D. But the patient has to know this and the pharmacy has to know this. And sometimes it's a problem that's dropped at our doorstep with, I don't know what to do. It's like, all right, here's what you do. I need to talk to the pharmacist. I need to have the pharmacist contact the LINET program, and I'll walk the pharmacist through. So this has to be done during the regular pharmacy hours and also during regular business hours that the LINET program is available. Usually takes about a 15-minute phone call and the LINET process is set up for the individual. It's temporary because the next step is we get the patient into Part D so that they are fully functional within the Medicare and Medicaid system. But that's a problem. And again, not knowing that and not being prepared and not helped transition into that can create a blip in the situation. And that's typical for individuals that start in Medicaid and rely exclusively on Medicaid to transition. Individuals that are on Medicaid because of their poverty, individuals that are on Medicaid through SSI or MOD or some reason, and then reach a Medicare eligibility and no one's told them how this works and what's supposed to happen. No one's reached out to an entity like us and said, help me understand what's going to happen and navigate us through the process. When it works, you're relying on your Medicare Part A and B card, your red, white, and blue card, as the demonstration of your primary coverage. Your Medicaid is going to be secondary. Your Part D is going to be representative of covering your prescription meds. And for things that Medicare doesn't cover at all, like dental or eye care, Medicaid is going to represent more than just a secondary benefit. Medicaid will pick up the cost. Now, the problem is you have to go to providers that accept Medicaid. Now, the problem is not going to be with Medicare. Like I said, invariably, just about any provider you would go to will say, yep, I definitely accept Medicare. That's not my problem. They might say, I don't accept Medicaid. And that's where the problem is. Medicaid is based on limitation. And although a majority of providers will accept and work within the Medicaid system, there's a significant minority that will not. And this is where the limitations come into effect. Limitations on who's going to accept Medicaid as a secondary payer, and limitations on things like what dentists and what ophthalmologists and what other kinds of non-Medicare covered services are going to accept Medicaid. And this limitation tends to force individuals to be aggressively on guard for looking for guaranteed accessibility for service. And this is inherent to the problem. And I'm going to show you a way, if you choose, it's not mandatory, but it's certainly an option, that you can work around that possibility of limitations if you have the means to do it. But start with the premise that individuals that are going into a dual eligibility status are relying on Medicare itself, Part A and Part B, as primary, and thus they have the reach that Medicare A and B allows them, but they're relying then as a secondary benefit, a supplement, the Medicaid system. The Medicaid system will not cost that beneficiary any premium amount. It will be comprehensive. It'll look like a good Medigap covering the entire balance that Medicare A and B doesn't pick up. but it's going to have the limitations of what providers are willing to accept the Medicaid card. So this is what it looks like. And the Medicaid, what used to be the access card years ago, a direct manifestation that you have Medicaid and it's going to be the state of Pennsylvania that represents Medicaid coverage. Half dozen years ago, the state of Pennsylvania abrogated that responsibility. Sounds a lot like what the federal government has been pushing for, shifting responsibility to personal, private insurance products. Only in Pennsylvania for Medicaid, it's pretty comprehensive, that shift to privatization. Through a program called Community Health Choices, a significant number of the people now in Medicaid rely on private insurance companies called MCOs, managed care organizations, to represent their Medicaid coverage, essentially an HMO type product. So your combination of products is going to be Medicare A and B as primary, which gives you reach for service providers, Part D, which has limitations, but that's going to be taken care of with another benefit called extra help, and Medicaid through these MCO products, which have limitations of where you can go and what you can get, and uncertainty as to where am I going to be able to get the care for the balance of what Medicare A and B is not going to pick up. This is now the weak link in that process. Economically, it does a good job, but in terms of accessibility and reach, not such a good job. So with the current managed care situation, with the current reliance on MCOs picking up the responsibility that the state used to in its access card manifestation. And by the way, you still have an access card. You can still use that for certain things. But for picking up the balance of your inpatient and outpatient services, it's going to be the MCO card. And it's going to come from one of three companies. You're going to utilize either AmeriHealth, Pennsylvania Health and Wellness, or UPMC. These are the three private insurance companies that have been contracted by the state of Pennsylvania to represent Medicaid coverage. So when you're using this model, that MCO that represents Medicaid is going to be UPMC or Pennsylvania Health and Wellness or AmeriHealth. And it's going to look very much like an HMO. Now, what they're also going to try to do, they meaning the private insurance companies, and even if not them, other private insurance companies, Highmark and Aetna, and I could keep naming a bunch, they're going to try to do something else. So be aware. When an individual is now dual eligible, Medicare and Medicaid, they certainly can use Medicare A and B as their primary. They at least have the reach that Medicare A and B offers and the full context of coverage, and they can supplement it with the Medicaid. And at least cost-wise, it's fully covered. But many individuals are propositioned by private insurance companies, through brokers, through marketing, trying to entice that individual to give up reliance on Medicare Part A and Part B and pick up what's called a Special Needs Advantage Plan, a SNP plan. Now, that's not the MCO. It's the alternative to Medicare A and B. It is an advantage plan, an HMO, offered by a private insurance company. And like I mentioned before, of individuals that are simply in Medicare, it abrogates relying on A and B. And now you are required to stay within their network and hope that their network matches with their network. It's a network and a network. Now, to make it easy, the MCO companies that represent Medicaid also sell special needs plans. And what they'll say, and they'll try to turn this into a positive premise, that our providers in the MCO are also the providers in the SNP. And by getting this and this together, you know for sure that there's going to be certain doctors and hospitals and facilities you're going to go to that will accept both the MCO HMO and the special needs HMO. And happy you are, except you're still limited to those places. You cannot go wherever you want, and you cannot step outside the boundaries of your region without worrying about, will going to a place outside of Pennsylvania accept my MCO and my special needs plan? If I really want to step beyond the boundaries of this local area for services for my unique medical problem, I want to go to Johns Hopkins, I want to go to Sloan Kettering, I want to go somewhere else. The reason I have Medicaid is not because I'm impoverished, it's because I need the help for my personal care at home or institutional care. Medicaid is helping me with that, and as an addendum, it's also helping me with my cost of health care. But it's also trying to impose on me limitations, initially limitations based on the MCO, but also limitations now if I'm enticed to also pick up this. Now, for some individuals, let me tell you, they're perfectly okay with the limitations, their premise of how they're going to be cared for, especially individuals that are in long-term nursing care facilities with a minimal of medical care and mostly personal care, are not looking for complex healthcare solutions. They're looking for simply simple solutions in the coverage they have. And this looks attainable. The guy that sits down with them and talks about their insurance company's MCO is also going to try to sell them on the special needs plan and say, look, I'm going to keep your life simple. I guarantee you, if you take this, they take this, or if they take this, they take this. And I'll make it even easier. I'll roll in a Part D coverage. You don't have to worry about picking that up. And the other kinds of stuff that are extraneous to Medicare, the dental, the eye care, I guarantee you there'll be a network of providers that will do that for you. You don't have to look. I'm going to take those burdens off your plate. Now, keep in mind, you're going to be limited to certain providers, but at least you'll know those providers will take both the SNP and the MCO. And isn't that what you're really looking for? If that's what you're really looking for. What if you want more? What if you want to reach out beyond that and have access to wherever you want to go? What if you don't want to worry at some point if one insurance company goes to war with another, like is prone to happen sometimes? One provider system goes to war with the other, as is prone to happen. Are you going to be caught in the middle of that conflict that your providers happen to be straddling both and you have to give up some to keep the others? Who knows? What if you're looking for something more effective? What if, rather than a SNP plan or even an MCO, what if you don't want to stick within a network of providers? What if you want to maximize your full utilization? Well, here's a third option. And again, this is not for everyone, but this is a way to guarantee a more maximized utilization of the healthcare system. And we do this with certain clients that are economically capable of affording to do this. So this is not for the person that is marginally economically endowed, a person who barely can afford the cost of healthcare. And so Medicaid is a godsend to them. Those individuals are going to transition into Medicare, and they're going to have Medicaid as their secondary benefit. So they're either going to use Medicare A and B primarily, backed up by an MCO Medicaid product, and have certain limitations, or they're going to seek to maximize their reach and the coverage without relying on Medicaid at all. So what they're going to do is they're going to enroll in Medicare A and B, or if they're already in Medicare as they're transitioning into Medicaid, they're not going to give up their Medigap product, as they're going to be encouraged to do. Oh, you have Medicaid now. You don't need your Medigap. No, I think I'm going to hold on to it. Or economically, I can afford, when I enter Medicare, to also pick up a private insurance supplement, a Medigap. Now, how much is this going to cost? Like I said, additionally, about $100 to $150 a month on top of the other costs. But effectively, that means that Medicaid now is a tertiary benefit. It's at the bottomest rung of the ladder. When you go to a doctor or hospital, you're saying, hey, doc, you accept Medicare, right? Yep. Okay, here's my Medicare A and B card. And how am I going to pay for the balance? Here's my Medigap. It will pay the balance of A and B. You have anything else? Yeah, but I won't need it. My Medicaid card. And because if a doctor or hospital or provider accepts Medicare A and B, by law, they must accept any company's Medigap. They can't turn down a Medigap product if they've already agreed to accept Medicare. And thus, between Medicare A and B and a Medigap, you can go wherever you want, not just in this region, but in the entire United States to access the care. Now, for lots of individuals that are dual eligible, that's more than they need. And paying $100 and something a month extra to have this extra layer of coverage is more than they want or more than they need. But for some individuals that absolutely positively want control over where they're going to go, keeping their providers and having the ability to get new providers at their discretion, this extra $100 or so a month is worth the effort of paying. So it's just an option. It's just a consideration. I told you I would tell you about two other things. One in particular, one is an absolute godsend in guaranteeing the cost of prescription medications are going to be quite affordable. And the other, for some individuals, helping them also with their Medicare Part B premium, that $170 or more dollars, although to be eligible for this is definitely going to be the $170. The one is called the Medicare Savings Plan. That's the thing that helps with the Medicare Part A, if there is one, certainly the Medicare Part B premium. And there's a benefit that helps with the cost of prescription medications. That's the LIS program, Low Income Subsidy, also known as Extra Help. So there's really three products you're thinking about if you're dual eligible. So I have to have Medicare A and B, whether I use it or not, whether I'm using a special needs plan in tandem with my Medicaid product or Medicare A and B. I have to have Medicare A and B. So how am I going to pay for that? Well, if you meet the criteria, you can get help paying for the Part A and or Part B premium through the Medicare Savings Program. Okay, I have Medicare A and B, but I can't afford to pay the balance that Medicare A and B doesn't pick up. Well, what am I going to do about that? That's where Medicaid comes in. It can act as a supplement, albeit through an MCO and with the limitations of the MCO, but it will pay the balance of what A and B doesn't pay if you go to providers that accept the MCO. Yeah, but what about the meds? That's where I'm getting pummeled. And there's a program that will help with that. The comprehensiveness of dual eligibility, Medicare, and the benefits that work in tandem with the Medicaid system can guarantee a reduction of the costs and pretty much a zero cost for accessing healthcare for individuals that meet the criteria. So the Medicare Savings Program, it's actually three levels. QMB, Qualified Medicare Beneficiary Program, SLMB, Specified Low-Income Medicare Beneficiary Program, and QI1, Qualified Individual Program. What you have to take away from this, there's lots of detail and there's lots of points in terms of getting into it and what's counted and not counted as far as income and assets. But for this purpose, the takeaway is by utilizing any one of these three programs, combinations under the Medicare Savings Program, you eliminate the Medicare Part B premium. And possibly, if you meet the criteria for QMB, you also eliminate the Part A premium if there is one. But the more important concern is eliminating that Part B premium, the at least $170. It's an income and asset-based criteria. If you meet the income and the assets, there's some set-asides. There's some don't have to count towards the income or the assets. But if you meet that criteria, then you're going to have assistance for that cost as well. And again, when you get this table, you can reference it. But suffice to say, every year there's an income and asset requirement. Staying below that gives you access to this benefit as well as Medicaid. Some people that are in Medicaid, ironically, are in Medicaid with income and assets or income or assets above this. So they're going to get the Medicaid benefit, but they're not going to be eligible for the Medicare savings. And some people that are in Medicaid do have income and assets low enough that they're also eligible for this program. So not only are they getting help with what Medicare A and B doesn't pick up, but they're also getting help with the getting of the Medicare A and B itself. But that's not as important as this one, extra help. And it can be based on income and assets. But here's the good thing about extra help. If you are eligible for Medicaid, you are automatically eligible, regardless of how you got into Medicaid, regardless of what your income and assets are. If you have Medicaid, you also are eligible for LIS. So one begets the other. Medicare savings has its own standard that you have to meet. This certainly has its own standard, but that's bypassed as long as you are in Medicaid already. So it's a federal program. It's actually administered by the Social Security Administration. I don't know why, it just is. And it's purpose-built to help provide significant assistance for the cost of prescription medication. There's a full benefit level and a partial benefit level. The full benefit and partial can be attained by meeting income and asset requirements. But for our purposes, as in we're dealing with a person who is dual eligible, they are in Medicare and Medicaid, whether it's one first and the other second or vice versa. If they are in Medicaid, once they go into Medicare, they are automatically eligible for full LIS. And the value of that, they will not be subject to a donut hole. The premiums of their Part D plan will be paid for if the Part D plan's premium is below a certain amount. And honestly, considering that the co-payments are going to be pretty well fully met by the LIS, this means that a modestly priced Part D will work quite nicely and definitely stay within the premium range that the LIS program will pay the entire premium amount of the Part D. Any deductibles that are imposed by that Part D plan will also be met by LIS. For all intents and purposes, no matter what the cost of the medication, in tandem with Part D and the LIS program, the individual will pay usually less than $10 for any medication and significantly less than that for generic medications. And here's the interesting thing. If the reason the individual is in Medicaid is because they're in a long-term care facility or they're receiving care at home under the waiver program, the co-payments for both the generic and non-generic medications are zero anyway. So the worst case scenario, using this model for determining what's my co-payment going to be, the worst case scenario for non-generics, no matter what they really retail for, is just slightly under $10. The more likely scenario is it's going to be about $4. For generic meds, less than $4 at the worst case scenario, better case scenario, about $1.35. And in the case of why am I getting Medicaid? Well, because I'm in a long-term care facility or I'm receiving my care at home through the waiver program, then don't worry about it. The copayments are even reduced further to zero. This is the big game changer. Being dual eligible means your medications are accessible at a truly affordable amount, no matter how much they really cost. So Medicaid certainly is a benefit to individuals of low income that can't afford to pay for their in or outpatient healthcare, but by far in immediate and daily utilization is the access to the LIS benefit. Now, understanding how the LIS coordinates, how it comes into effect, and how individuals are on the lookout if they started in Medicaid and they're transitioning into Medicare, and now they're going to be notified that their prescription medications are no longer going to be under Medicaid. Their prescriptions are going to be under Medicare, and they need to get a Part D plan. And if they don't, they're not going to be able to fully utilize the LIS program. But also, what the LIS program is now starting to do is notify them well in advance, in most cases, and that telling them if they don't select a Part D plan, that a Part D will be selected for them. Sometimes takes the burden. Only often the person doesn't know a Part D plan's been selected for them. There's ways to find out, but the family won't know that. And again, usually our office is brought in to make sure their benefits are in place and discover what they are. And if they're not in place, to make sure they're put in place and utilizing as a stopgap that LINET program that I mentioned before. So part of this discussion is to make sure you guys understand that there are resources out there to help you understand what these benefits are going to be, how they work, what choices and options you have, and how to effectuate that, and how to know that you're making the right choice and how those choices are going to be utilized. When used well, the Medicaid system in tandem with Medicare typically eliminates the cost of healthcare. And if used strategically, can allow the individual to access the services typically at places that they want to. But understanding how it works and understanding what steps have to be taken and when they have to be taken are essential for the family to wrap their head around or find resources that can do that. We happen to be one of them. Looks like there's some questions. So
there are, Bill. Would you like me to read you the questions? You have quite a few.
Go ahead.
So thank you.
Go ahead.
That was a fantastic presentation. The first question is, income is MAGI, not taxable income. Is that correct?
That's correct. And it's MAGI as in modified adjusted gross income. So there's some things that aren't necessarily taxable, like Social Security benefits are going to be counted towards that. And what this person is referring to is this. How do you know what the income is when you look at your tax return? Best thing I can recommend, it's still going to be modified somewhat. Pull your tax return from 2 years ago, look for the line that says this is your adjusted gross income. This will give you a tip off. Add in certain things. The most likely certain thing is your Social Security, even though they're not taxable, they're going to be still counted, and see what category you're in. Remember, you can always say, wait a minute, this is not fair. My income isn't nearly like this now. And you can request a reconsideration. Next question.
Great. Thanks, Bill. Are traditional IRA to Roth conversions eligible for exclusion from MAGI?
Easiest way I can say, if whatever the action you're doing generates a show of income under the adjusted gross, modified with things like the non-taxable Social Security portion, certain non-taxable investment benefits, although the Roth, that's not going to show up as a taxable event. And generally, that's not going to be counted in certain other kinds of capital gain investments aren't going to be counted. Best way I can recommend, Medicare CMS produces a chart that has, these are the incomes we count, these are the incomes we don't. And honestly, I mean, it's going to be one of these things where it's something that happened 2 years ago. So this is like, oh, I'm going to try to strategically play this. No, you're not. You're going to do what you do, because inevitably, whatever you're going to do is going to happen to trigger a consideration with Medicare. And I have clients that go to great lengths to try to game the system so they're not counting the income, so they're not putting themselves into the bracket. And eventually it's going to happen. Eventually this income is going to come to play, or they're going to live in a diminished income capacity for the rest of their lives out of fear that for 1 year, they're going to have a reckoning where they're going to have to pay a larger amount. So unfortunately, it is rigged to impose some kind of responsibility for individuals that have a 1 year wealthier. But Medicare also have become incredibly generous about saying, if this was an anomaly, and you can show me that it is not a normal facet of your year, then we're not going to count it. You get the $170.10. You just have to know how to present it effectively. So best recommendation for any of the questions about, oh, what do I count? What do I don't count? Quick answer is look at your adjusted gross income. Are there modifiers? Yes. What are they? There's about 40 or 50 examples of modifiers that just take a look at what they are and see if they apply in the case of your year's return. Next question.
Thanks, Bill. Can you choose to enroll in Part B while still working and insured as a secondary coverage?
Sure, if you want to. The reason people tend not to is they don't want to pay that $170, or, oh, that's going to be a year that I'm definitely making more money, and I'd rather not pay an IRMA on top of the misery of $170. So yeah, it's if you are, well, and let me clarify what makes it essential to know whether you're going to be using Medicare as a primary or a secondary benefit. For example, I work for a small employer. We only have 8 guys there. My Medicare B is not going to be secondary. It's going to be primary. And in fact, I may not even have a choice. When I turn 65, I may be compelled to go into Medicare because my employment group plan, because it's with a small employer, going to say, I don't care whether you're going to get Medicare or not. Once you turn 65, we're going to automatically drop to a secondary status. They may also say, no, we won't do it unless you pick up some part of Medicare. Oh, you picked up the Part A? Well, guess what? You've just enrolled in Medicare and we drop to a secondary status. So the idea when you say, oh, can I use it as secondary? That implies you work for a large employer. So if I work for a large employer, what comes first? My employer health benefit, always. And can that abrogate and say, oh, now that no, that is illegal. But can I supplement it? Yep, you can get Part A, you can get Part B if you want to pay for the premium for Part B, and you can use that to supplement. But honestly, if your employer benefit is that crappy that you need to get A and B to supplement it, you should be thinking about dumping that employer benefit and simply going into Medicare. I know there's sometimes reasons not, because I also need to keep my spouse and he or she's not eligible yet for Medicare, and that's the reason. So I'm going to keep one and both. But sometimes it's just time to give up the ghost and start migrating into Medicare. And if, again, you're thinking, oh, can I use that as a secondary? How about using it as your primary and getting a Medigap, which may very well be cheaper than what you're paying for your employer-provided product? Next question.
When you purchase an Advantage plan, do you also have to pay for Part B based on your income?
Absolutely. Yes, you do. Okay.
So Medigap is also a replacement plan for traditional A and B?
Nope. Medigap is a supplement for, here, let's get back to the chart. Option 1, your Medigap is a supplement. It always is, always will be. It is secondary. Medicare A and B is primary. You go to doctors and hospitals that take Medicare, which is essentially all of them. If they take Medicare, they must take your Medigap. They cannot turn it down. That means any company's Medigap, no matter what the insurance company is, will be taken by any doctor or hospital that agrees to take Medicare. A good Medigap, which is pretty much just about any of them, will pay pretty much the entire balance of your health care. It works in tandem. It doesn't replace Medicare A and B. It combines with Medicare A and B. What replaces Medicare A and B? HMOs and PPOs. What are they? Companies you're familiar with, Highmark, UPMC, they're Freedom Blues and Security Blues and UPMC this is and Vantra's that's. If they have the word HMO or PPO, they're an Advantage plan. They replace Medicare A and B. And back to the question before that, oh yes, you do have to have Medicare A and B. You are not allowed to have an Advantage plan unless you have Medicare A and B, but you don't get to use Medicare A and B, you just pay for it. It's like belonging to Sam's Club. Just having the card gets you in the door. It doesn't mean it actually gets you anything, maybe some free samples, but Medicare doesn't deal in free samples. So it just gets you in the door for $170 or more. Next question.
Okay, so they ask, can you clarify if you go with traditional Medicare and add your prescription plan, of course, this is a couple parts, Bill, so I'll read the whole thing first. Is there cost sharing involved? You mentioned traditional Medicare covers 80%. So does that mean we cover the additional 20% through copays? I'm trying to understand what the advantage is going with traditional Medicare plus required drug coverage might be.
Okay. If you just do Medicare A and B and traditional drug coverage, you've missed a big element. And you can certainly do it, but what compelled you to say, this doesn't seem to make sense? It doesn't make sense. If it's just A and B and a drug plan, no, you're missing the component of the Medigap. You'll only be covered for about 80%. For your in and outpatient services and whatever the Part D plan. You get the other product, which is the supplement called a Medigap. Look at the yellow box. And the reason you're getting that is whatever A doesn't pick up, the gap will pick it up. Whatever B doesn't pick up, the gap will pick it up. So you go to the hospital. The hospital says, how are you going to pay for it? Here's my Medicare card. Look at A, it pays 80%. Now here's my gap. It will pay the other 20%. Go to a doctor's office. The doc says, hey, how are you going to pay for this? Here's my Medicare card. The B will pay 80% and the yellow Medigap will pay the other 20%. You go to the pharmacy, bring some money because the gap will not help you with Part D. Medicare A and B won't help you with Part D. Part D is all you got until and unless you are in some other benefit program like LIS or PACE or something else that's going to help you. That's the weak link. And again, just to drive this point home with option 2, you can't buy a supplement with option 2. With option 2 in the tan box, you have Medicare A and B, you pay for it, but you don't get to use it. The only thing you get to use is the HMO or PPO. They're cheap, $0, $20, $30, certainly less than it would cost from Medigap. And they give you other junk as an incentive, but they will never, ever, ever be as comprehensive as Medicare A and B and a Medigap for your in and outpatient services.
Okay,
Next
regarding the 24 months of benefits from SSA for someone who is disabled, is that benefits as adults or does the time they receive benefits as children count? And does this occur automatically when they reach that time frame?
It's whenever the Social Security Administration says they are disabled. So whatever day the Social Security Administration says, as of today, we recognize you as disabled. Now, often they'll go back in time. Oh, okay, we're recognizing you as disabled years ago or months ago. Whatever that day, they start the process of determining when they're going to pay you your disability benefits. Once they arrive at that date, so day of disability, then day of you're entitled to a benefit, that day starts the countdown of the 24 months. So it's, I'm disabled. Does that mean I start my 24? Not yet. You got to start collecting your disability benefits. Okay, I'm getting my benefits now. Now I'm going to start counting 24 months. Whatever that day is, 24 months later, congratulations, welcome to Medicare. Who knows what those dates are? The Social Security Administration. You might argue with them. You might say, wait, this is wrong. And they might say, you're right, we're wrong. Not likely. But ultimately, who's going to dictate the day you're disabled, the day your disability starts, and therefore the day you are automatically eligible for Medicare based on presumably the 24-month wait, that is going to be dictated on a timetable set by the Social Security Administration.
Thanks, Bill. Someone asked where they could get some of this information specific to New York.
Depending on the agency, you're going to have someone representing the Medicaid system for New York. Medicare, good luck. I've had people from New York calling me saying, I can't find anybody other than guys selling Medicare that can talk about it. So I'm sure there's got to be, New York's a big state. There's a lot of people up there. But if you have questions or issues about Medicare, Medicare is Medicare. It's a national context. So what is good for New York is good for Pennsylvania, is good for Kansas and Mississippi and all states in between. Medicaid, though, again, I would recommend going to New York's version of the Medicaid system. In Pennsylvania, it's called the Department of Human Services, DHS. There's definitely a New York equivalent. I would be seeking out someone in their system that is accessible and adept. Support systems, they exist in New York. I can't qualify how good or bad they are. I usually don't work with them. And as far as Medicare, I can't recommend any system in New York that's going to be, a proven track record about being competent enough to navigate you through this kind of stuff. So if it's about Medicare, our office will be happy to talk to you about it, even though it's in New York.
Can you address eligibility of an individual with a lifelong disability from birth who is under age 65 and is on SSI and their eligibility for Medicare when one parent reaches 65? And if that parent chooses to delay enrollment, does that delay the individual's Medicare eligibility?
Well, the likelihood of what's going to trigger the eligibility for Medicare is not that the parent turns 65 and thus them turning 65. The parent makes the individual child eligible for Medicare. There's an interim thing that happened. Parent became eligible for a combination of Social Security and Medicare. It was the reclassification of the child as no longer SSI only, but now a disabled individual. And this goes back to a question before. When did Social Security redefine the individual as, of course, they were truly disabled from birth, but they weren't recognized as disabled. They were recognized as SSI eligible. Big difference. But at some point, that child is going to be recategorized in the eyes of Social Security as a disabled individual, and a clock is going to start ticking for 24 months. And they're going to be in Medicare now based on disability. Why didn't they go into Medicare when they were 3 years old? I mean, God knows they were disabled at least 2 years at that point because they weren't on Social Security disability, SSDI.
We lost your sound, Bill.
They were on SSI. Do you have my sound back? Can you hear me now?
I can hear you now.
Okay. I'm going to ramp it up just in case. Those individuals were not recognized from day one as disabled, or the 24 months would have clicked away. And by the time they were 2 or 3 years old, congratulations, you're in Medicare. They were receiving SSI benefits, which is different from SSDI. To go into Medicare, you have to be aged in, disabled in, or you have to be in based on end-stage renal. If they're SSI, they're not SSDI, and thus the 24 months hasn't told yet. So at this point, we have to wait until a condition is met at some point later in their life that they're recategorized as SSDI eligible, plus 24 months, plus welcome to the Medicare system.
Thanks, Bill. When talking about how Medicaid eligibility equates to automatic LIS eligibility, is it only AdCare Medicare, or previously called full Medicaid, or can it be categories such as DAC Medicaid, Freedom to Work, 1619B for former SSI beneficiaries, etc.?
Well, here, this is, I don't know if this clarifies it a bit more. You cannot have LIS unless you're dual eligible. So if you are deemed to be dual eligible, that requires that you're in Medicare. And being in Medicare and a form of Medicaid is what triggers the LIS. It's less triggered by Medicaid and typically lays dormant for the individual. Oh, I'm just in Medicaid. I mean, one of those forms of Medicaid. Yeah, but are you in Medicare? Well, no, I'm just, because usually when that individual transitions into Medicare and Medicaid, the recategorization is effective based on a general definition of dual eligibility. So from LIS's standpoint, they could care less what the form of Medicaid is, as long as it's a recognized form of Medicaid that works in tandem with Medicare. If that's the case, they are dual eligible. And if that's the case, they have LIS.
Okay, next question. My son has dual coverage through Pfds waiver. He has a Medicare number and an access card and a prescription plan that was assigned to him. How do I get him assigned to one of the MCOs you listed? The caseworkers and supports coordinators have not been able to help them. Any suggestions?
It's supposed to happen automatically, but lots of things are supposed to happen. All right. Oh, God, I was hoping this was resolved, but apparently it's not. You cannot directly contact the MCO. Oh, you can, but they're going to say, we have to work through something called an independent enrollment broker. I had hoped that this had resolved itself. This was pre-pandemic train wreck stuff, and it got train wreckier during the pandemic, but there was an assurance that they were working through this. When they rolled this out, and I have not much good to say about this process, if you gather from the tone. First of all, just the abrogation to private insurance to take over the responsibility. And to make it even worse, they won't let the individual patient reach out to the MCOs. You have to do this through an intermediary. It's not a broker in the sense of Jack the broker as an office down on Fifth Avenue. No, this is an agency that is designated and paid quite a lot to be the go-between between the patient, the individual eligible, and the MCOs. You're supposed to work with them. Now, here's the train wreck part. Which one am I supposed to get? The independent enrollment broker says, well, you're supposed to do your own research. How the hell can I do research if I can't reach out to anybody? They keep saying, sorry. Yeah, it's like, you have to make your choice. I can't look at anything to make a choice. Aren't you guys supposed to help me, independent enrollment broker? No, we just do the enrolling. Now, they're supposed to be getting better. They're supposed to be more helpful, more circumspect about this. And the three MCOs are a little bit more aggressive in saying, we'll sit down with you and help navigate. But at its worst, which was not that long ago, it was like, wait a minute, who's on first, who's on second, Abbott and Costello? How do I know what's the best one? Well, you have to check with the company. I can't check with the company because they won't let me check with them. I have to work through the independent enrollment broker. IEB keeps saying, oh, we don't do that. Just pick one. No, don't just pick one. You might not like the network. You might not like what they're doing. So here's what I would recommend. Reverse engineer it. Decide which doctors and hospitals and care providers you absolutely want to keep. Ask them, do you guys know what an MCO is? Yes. Do you work with this particular MCO? Yes. Okay. I guess this is going to be the best one because it allows me access to all the providers I want. Will they offer me other junk? Yes. Can I find out what it is? Yes. How do I do it? By aggressively banging on the door and saying, show me the other stuff you have. What other kinds of perks do you offer? Alternatively, hope that the independent enrollment broker is becoming more adept at helping you navigate through this. I've heard they are, but I've not seen it in practice. And I get what you're saying. It becomes problematic. And theoretically, if you haven't selected an MCO by the time your dual eligibility arises, you're going to be assigned one. Now it's like, okay, maybe that's not going to be the best one. Well, the good news is you can move from MCO to MCO fairly regularly throughout the year. This is not, oh, I have to be stuck with it for the entire year. No. Alternatively, you can drop the MCO and pick up one of the other two. So you may be forced to take one because you didn't make a choice and one was imposed on you. And believe me, that they do aggressively do. If you haven't picked one, by the month you're now a dual eligible, one's been assigned. You may not know which one it is because they didn't necessarily tell you, but one's been assigned to you. How do you find out? Reaching out to the independent enrollment broker or simply reaching out to DHS. Oh my, yes. But they should be able to identify. And also you can attempt to reach out to Centers for Medicare and Medicaid Services. They should have access to that same information. But usually you're notified at least a month or two before the dual eligibility is to occur that you need to select an MCO. You are now eligible for one, and here are the three possibilities. Reach out to them, and here's their contact information. If you don't select one by a certain date, the independent enrollment broker is going to be instructed to enroll you in one of those. And if you don't like it, you can always change it later during the year, but we're going to put you in one to begin with. That's the protocol of how it's going to work. And usually the individual is able to get someone at the MCO to sit down and talk to them about the products. They didn't, they were more reluctant because they were saying, can't step on the territory of the IEB. But more and more, if you're persistent, somebody from UPMC or AmeriHealth or Pennsylvania Health and Wellness will say, here, let me at least give you an idea of what to look at. But the best thing you can do, remember, it's about networks, it's about limitation. You want to make sure the doctors that you want to keep are going to work with that, and maybe not the doctor themselves, but someone in their billing office is going to know which of the MCOs, if any of the MCOs, they're going to work with. I would recommend that as your starting point to determine which MCO is going to be the best one. Next question.
Bill, so we're reaching the end. Do you have time for a couple more questions?
I'll stay as long as you want me to.
Okay, great. Thank you. The next question was for individuals who are looking for IDD waivers. They cannot have CHC. If they are awaiting waiver and reach that point where they become dually eligible, how do they avoid CHC?
Well, certain individuals are going to be in Medicare, and certain individuals are going to be in Medicaid through one of the ways which is not prescribed as requiring. However, what I understand is once the individual is categorized from DHS's standpoint as dual eligible, however the portal is, as in there are people that have only Medicaid, various kinds. There's probably 30 different ways you can have Medicaid. Some of them do not impose CHC. Most of them do, simply by being Medicaid only. But one of the absolute categories is if you're dual eligible. That means pretty much if you're Medicare and any of the forms of Medicaid, you're dual eligible. CHC is now the operative format. It doesn't matter if that Medicaid was non-operative for CHC before. Once you are in a dual eligible status, meaning Medicare is the triggering premise for dual eligible, and Medicare is the triggering for having to rely on the MCO.
Great. Is someone eligible for Medicare if he does not have enough working quarters? How does he become eligible?
Well, there's two ways. He works, but let's say there's no way this person is going to be able to continue working. If the person has insufficient quarters and they do not have a spouse that they can piggyback on for those sufficient quarters, you can rely on Medicaid under certain circumstances to pay your Medicare Part A premium for you. And here's the reason why. Medicaid is secondary. Let me go to a spot. Medicaid is secondary, but in a more aggressive way. If for whatever reason, you cannot have some part of A and B, like you haven't worked enough, you haven't paid in, then Medicaid is responsible for the full cost of your inpatient care, which they don't want to be. They will find it far more expedient to pay for the cost of you having Part A rather than pay for the full cost of inpatient care treatment. So what happens is if you are eligible for QMB, if you are in Medicaid and you are eligible for the assistance program that pays for your Medicare Part B program called QMB, not SLMB, not QI1, but QMB, that means your income and assets have to be below that certain amount, then Medicaid will pay for your Medicare Part A premium. Because again, they find it more cost effective to pay that than the risk of paying full cost for in-hospital. If your income is or assets are large enough to presume that you are not eligible for assistance, then you are presumed to have to pay for your Part A. But if you don't, here's also what happens. You go into hospital, you don't have Part A, you just have Part B. And now you're billed for the full cost of the hospital. And guess what? It descends back down to the unbalanced. Well, you couldn't have a SNP plan because you need A and B. It would be this. You have Part B, but not Part A, and Medicaid's going to be responsible for picking up the balance. And here is what I've seen happen. Even if the individual is not eligible for the QMB, Medicaid, because they don't want to be stuck with a cost, is going to say, okay, you know what? We're going to cover the balance of whatever it costs to put you into Part A. Here's why they don't tend to worry about that. And there's always an exception, of course. If the individual had not accumulated enough quarters for Part A, it is likely they're impoverished to the point that they are eligible for QMB. I've seen it happen in a couple rare occasions that it's not that case, but almost every time I've seen a situation that the person doesn't have enough quarters, the person is also economically low enough that they're eligible for the QMB, which eliminates the problem because the state steps in and says, we're going to get you Part A anyway, even if it costs $500 a month, because it's way cheaper than paying for you being in hospital. Next question.
Great. Before I go to the next question, I just want to mention to those still online, if you go to the chat page, while you're listening to these questions, some of those in attendance have offered some good resources, like for the person who was looking about services in New York, and there was a link, and then there was also some information on MCO comparisons and where you can find a link for that. So
actually, while we're going, and believe me, you guys really need to establish a support group. Here's what I've lived through. Here's what I've come up with. we are one support group, but I've often thought about, reaching out and getting together on a regular basis, once every couple of weeks or once a month, a support system of people that have lived through this and said, here, let me share what I've experienced trying to navigate with an MCO or navigating recently with a independent enrollment broker, or, hey, I'm from New York too. Let me tell you what I know. This is about networking. This is about finding not just a resource, but a number of resources based on experiential process, based on a fundamental knowledge of it. And swear to God, do not count on government to be that omnipresent and comprehensive resource. You're lucky if you can get any assistance out of that. Usually you're cobbling together information from a number of places. And that's unfortunate. As this system is an incredibly fractured system, it also requires knowledge about not just one or even a couple, but multiple systems by which operates. We've created quite a toxic stew in trying to access healthcare. And it is unfortunate that that burden falls on families that are probably the least prepared to navigate through this crap. Next question.
Agree. Thanks, Bill. Does Medigap provide coverage for dentists and eye doctors?
No. For Medigap to function, it has to be something which is covered by Medicare Part A and Part B. Now, let me tell you that eye care is not your problem. The things that are going to be truly expensive in eye care, treatments for macular degeneration, glaucoma, cataracts, that's going to be recognized typically as a basic medical service. Essentially, this is not an absolute, but it's a pretty good rule of thumb. If the service you're seeking can only be done by an ophthalmologist, it's going to be considered a medical service. It's going to be covered by Part A or Part B, and Medigap's going to pick up the balance. If it is something that could be done by an optometrist, like lenses and frames and the examination to get the lenses and frames, it's generally going to be considered a basic service that Medicare is not going to cover, but that's not going to be economically onerous. Dental is where the problem is. It's pretty much the opposite. Anything you can imagine is going to be, oh, that's just ordinary basic dental. No, it's not. It's your major work on my mouth. What it really comes down to is Medicare saying we don't want to pay for it. If Medicare A or B doesn't pay for it, then a Medigap doesn't. And that's why I have the salmon colored box of non-Medicare services. And what I really mean by that is dental. And here's the bad news. Pretty much any kind of dental service you're going to find, dental coverage you're going to find out there to add on to your Medicare. And by the way, that also applies if you do option 2. Oh, well, they'll give me with my HMO through Highmark some dental. Yeah, but it sucks. It's limited to only very basic things, and the amount is limited. The kind of services that you are going to be inclined to want to use, the kinds of stuff for complex dental services that are going to cost thousands of dollars, you're not going to find a dental plan that's going to cover that. And worse, the dental coverage that you would buy to go along with your Medigap and Part A and Part B is going to impose a wait time, usually a full year, 12 months, before they'll cover the more complex services. Oh yeah, you can get your cleanings and exam, and we'll do that right off the bat. But you want to get, major dental services, the kinds that are going to cost you thousands of dollars, yeah, you better be covered by our plan for at least 12 months. Could I just pay you in advance? No, that's not the point. We want to make you wait for 12 because probably you're not going to be able to suffer through 12 months. You'll get it done in some other way, and we don't have to worry about it. That plus, by making you wait 12 months, that means you're less inclined to ever bail out of our product because you're going to have to start with a new product's 12-month requirement. We've built in loyalty by imposition of the wait time. It is probably the worst element. If you think Part Ds are crappy, wait till you take a look at what dental is going to look like out there in the marketplace. Medicaid, we're talking about dual eligibles now, will pay for the cost, except two problems. Problem number one, find a dentist that will work with Medicaid. Why? Because the dentist says the crap they put me through to get reimbursed is not worth it. Screw it. I'm not going to take Medicaid. Second, Medicaid is going to say, what, you want to do what to this patient? No, no way. Here's what you're going to do. You're going to pull out all their teeth and you're going to give them dentures. That's what you're going to do. You know what? That's not the kind of dental work I want to do. So you know what? I'm not going to work with you guys. The problem isn't just finding a dentist. The problem is, will Medicaid allow this kind of service? And we're into this kind of fight between the dentist's inclination to want to do good work, more comprehensive, complex work, and Medicaid saying, well, this is poverty and you get dentures. This is the problem. And you're going to be told, oh, if you get a snip, oh, we'll give you dental. What, to what level? Well, you know, like $500 a year. You understand that's going to pay for like one part of one thing. And I'm on Medicaid. It's like, what can we say? People tend to queue up at the Pitt School of Dentistry a lot as the way of accessing something close to comprehensive dental services. It is amazing showing up at Saul Call on any given weekday at well early in the morning when I'm going over to Saul Call to teach at the School of Pharmacy, which also shares with the School of Dentistry. And there is a queue of people desperately trying to be one of those chosen to get in. And invariably, these are people that are low income, have minimal, or they may even be better than low income. And a lot of them are on Medicaid, and they can't, even with Medicaid, find someone that will provide the kind of services they're looking for, or the wait time or the accessibility time is preclusive. It is easier to queue up on a winter day in front of Saul Call, hoping that they get lucky enough to get taken care of. Next question.
Can a dual person change their mind? If someone is enrolled in a SNP, can they switch to a different plan or a different SNP plan, or can they switch to the traditional Medicare setup with CHC as a supplement?
Yeah, they can. Throughout the year, there are designated non-enrollment season enrollment times. It used to be every month you could do it. They backed away from that for a number of reasons I won't go into, but periodically throughout the year, you can say, I don't like this SNP, I'm going to go to another one. Or screw all the SNPs, I'm going to give them all up and go back to Medicare A and B and use my MCO. So again, the combination of which you can in and out throughout the year is either I'm going to start with Medicare A and B and use my Medicaid MCO. I'm going to flip to a SNP plan and abrogate A and B for that time period. And whatever the SNP plan doesn't pick up, it's going to work in tandem with the Medicaid MCO. Oh, I don't like that one. I'll try another SNP plan. I'll try another MCO. I can in and out of these plans pretty frequently. And if I don't like any of the SNPs, I'm going to go back to Medicare A and B. Personally, this is my thought. If you cannot see a true value advantage of that SNP plan, something they're going to give you that is above and beyond Medicare A and B, I would go with Medicare A and B for the potential reach that it gives. I do not want to have to deal with a SNP network on top of an MCO. On the other hand, if I'm prepared to go with limitation, and that limitation isn't outrageous, if I'm going to do a SNP plan, I'm going to do the SNP plan in tandem with the same company's MCO plan and get some degree of an assurance that the network that works with the one will be the same network that works with the other, at least for the current time, knowing that if it gets less effective, I can always re-examine and bail to something else, which is why, if you can afford it, I'm recommending option 3. I have Medicare A and B, which gives me the ultimate reach nationally. I have a Medigap that if you take Medicare A, B, you must take the Medigap. And yeah, I'll put my MCO in a drawer and never mention I even have it. Go to the doctor. What do you have? A and B and a Medigap. You have anything else? You don't need to know that because it's going to pay for everything. The MCO is just that silly little thing that's just there just in case. Next question.
I get SSD for me as well as my daughter in her own name. I also get child support. Do I have to look at these? Do I have to look these up on the list you mentioned? Do you know, or do I have to look it up? And what is the URL again? And I can type in the URL for that list, Bill, in the chat.
Yeah, well,
box.
and again, what I'm not sure, SSD, I'm presuming means SSDI. So you're getting SSDI, daughter's getting SSDI. Are you also on Medicaid though? Are we just talking about somebody that's receiving? And again, I'm not going to compel you to, to chime in with another, but the question isn't quite as thorough as I want. If you want to,
she is on Medicaid, Bill. She is on Medicaid.
Okay. So if we are looking at a person who's dual eligible based on SSDI and Medicaid, daughter's the same thing. If what you're talking about is, which MCOs, you got three choices. If you're talking about SNP plans, there's a whole bunch of them. Pretty much just about any company that's selling an HMO or a PPO in this area is most likely also selling a SNP. And there's some that are very focused on SNP type plans or Medicaid centric plans. I'm thinking Gateway as a good example. The question really is like anybody using an Advantage plan, or in this case, an MCO product, make sure that that product allows you to access the providers you're looking for. Honestly, all SNPs tend to look very much alike in terms of their guaranteed coverage of the services. The question is the accessibility to the providers is what is the issue. And do not rely on the company telling you, oh, they're fine, we'll cover that. No. Suddenly you realize after you've signed up with them, that's like, no, I don't take that product. But he said, well, I'm sorry, what the broker told you, I don't take the product. Don't rely on the company or the broker, rely on the provider you want to go to dictate whether you can have access using this product. And as far as what all the products are, I'd recommend that, there's at least a dozen SNP plans, and the MCOs, there's 3 MCOs. And I can tell you all of them offer a SNP plan as well as in tandem with their MCO. Next question.
How do I find an intermediary? I have tried CMMS, DPH, County Supports Coordinator. No one knows anything.
Well, an intermediary for what? It's, if you're looking for someone that's, gonna act as a entity to get you enrolled, there are programs like mine which will assist you in the enrollment. If you're looking for someone to help you with an appeal, there are programs that will do that. If you're looking for the entity that will navigate you through the process, as in, help me make general choices, a program like ours can do it. But if you're looking for the entity that's officially required to do this, we're back to the independent enrollment broker and the 3 MCOs. Good luck. So it just depends on what you mean by I need an intermediary to do something for. That's going to depend on the situation. That's going to depend on the program like mine, or like I could name 5 or 6 other programs, what their bailiwick is for doing these kind of things. Some of them focus on only specific things, like navigating through the Medicaid system and filing certain appeals, but under certain circumstances and within limits of what their resources are. I'm thinking of the Pennsylvania Health Law Project. I'm thinking of other programs that say, okay, this is what we'll do, but it's so sometimes it's not just a question of, do you know anything? It's a question of what are you capable of doing? What do you have the resources to do? And what do you have, the inclination based on the definition of your mission to do? So, there are organizations that know what they're doing. Pennsylvania Health Law Project is a good example. But when you go to them and say, I need you to do the following thing with Medicare for me. No, we don't do that. It's like, because we just don't. It's the limitation. And it's the same thing with our program. There are certain things we'll do. There's certain things we won't do, simply because we have a limited number of staff and a limited number of resources. And if we tie it up with that one thing, that's it. Our office is shut down for anything else until we get that resolved. So it's unfortunate. If we had a couple $1 million more in budget, we could hire 7 or 8 or 12 or 15 more people. And oh boy, we could do all sorts of things. And it's not just who knows, it's who's capable of doing because of the limits of their own program's resources. Next question.
Let me see. If we choose Part C coverage, does that limit the universe of doctors and hospitals that one could choose from?
Oh, you bet. They're going to have Part C means a HMO or a PPO, Health Maintenance Organization or Preferred Provider Organization. And that means they're a network of doctors and hospitals and care providers. And if you're going to pick one, first stop is the doctors that you want to keep. Do you take this card? And they're only guaranteeing you for this particular calendar year. Once the calendar year's over, sorry guys, it's like we've changed the guys we're using on our network. They don't take the card, or we don't take them any longer. Got to find a new plan or find a new doctor. So that's the point of the limitations of the Part C. You're getting a cheaper product, like with a SNP, 0 premium, or even non-SNP, 0, 10, 30, $40, but you're trading it off with limitations. And one of the big limitations is a limited access to doctors and hospitals in their network. Next question.
I think this might be the last one, Bill. If a parent goes on Social Security and has an adult, it just says adult, I'm assuming they mean maybe adult child on Social Security since birth. Do they lose their skin if Social Security determines they are not eligible for SSDI? My son also works 20 hours a week through OVR.
I don't know if you're going to lose your skin, but I'm just not sure what you're getting at. It's
okay.
It's just, I want to ask more clarification on that. So,
okay. Well, Bill, I'm going to send out the slides and they'll have your contact information, on those slides. I'll also put my contact information in the chat so they could reach out to us here at Achieva, and we might be able to answer some of these questions and questions as well. And what we can't answer, we can certainly forward on to you, or like I said, they can reach out to you directly. I also put a Pennsylvania Health Law Project, their email address as well.
Let me quickly mention something, just so there's no hard feelings. And I really want to drive this point home. Pennsylvania Health Law Project is an incredibly competent organization. They are, if I am the guru for Medicare, they are the guru for Medicaid. Their métier, their strong suit is navigating people through the complexities of the Medicaid system, the Medicare Savings Program system, the LIS system. It is secondary to our program. We do a good job in the basics. The Pennsylvania Health Law Project, particularly someone like Aaron Guay, does a great job. The problem is there's like 3 people there. And within the entire state for the Pennsylvania Health Law Project, there's limited resources. So getting a hold of them to talk to you about, or more particularly to help you navigate through the problem of a denied benefit or a screwed up application or just making sense of something. It isn't that they don't know what they're talking about. They quite know what they're talking about. It's not a question of competency. It's a question of access, and therefore a question of their resource capability. So, the good news for us is we can usually resolve Medicare issues a bit faster, a bit more effectively, in a timely way. We can sail through a Medicaid situation 3 or 4 or 12 of them in the time that it takes the Health Law Project to sail through one Medicaid issue. Unfortunately, there is that tandem problem. Often, I'm brought in to be the Medicare end of a problem resolution when it's a combination of Medicare and Medicaid. And someone like Aaron Gway is brought in when it's solving the Medicaid issue. But there's the question of how many people in each program is available. And there reaches a point where we're tied up. We'll get to it when we get to it. I wish we had more resources. I wish the Pennsylvania Health Law Project had millions of dollars more so they could hire 5 more Aaron Gways or hire 5 more people that will turn into Aaron Gways after 10 years worth of experiential development. This is the systemic problem with our system. One, we have a fractured system of multiple agencies and programs that do some little part of the big picture and not a singular focused agency that take care of everything. And even within those fractured agencies, you have some pretty inaccessible and not very dependable individuals. Doesn't mean all of them, but you're always wondering, is this correct? Is this valid? And can I even get a hold of somebody? There are plenty of private programs like mine, like the Pennsylvania Health Law Project, but we are funded by grants, donations, and whatever other kinds of resources we can get a hold of. And those resources dictate the limit of our staff and the limit, therefore, of our capability of handling cases. So if you can get a hold of me or some of my staff, will be happy to help you navigate through it. But as the Health Law Project has pointed out, we can only take so much on, and we have limits to what we're prepared to do. Oh, will you take my case? No, I can explain what's going on and I can tell you what you need to do, but I can't get in the details of this. I don't want to speak for them. It's up to them to set their limits and the scope of their service. But I'm preparing you for the possibility that what you want out of them is not going to be as fulfillable, not because they're not capable, simply because they're limited. So, take it for what it's worth.
Thank you, Bill. And thank you for a fantastic presentation. I was just thinking to myself, I've been doing these webinars with Achieva Family Trust, I think for almost 6 years now. And this is by far the most questions we have ever had and the longest that so many people have stayed online. So thank you for such wonderful information. And for those of you, again, that have stayed on, I will leave the chat box up for a couple minutes because there is a lot of good information up there. There was someone that was interested in starting participating in a support group. There's some good website links up. So I'll leave that up for 5 more minutes if anyone wants to, go through the chat and check it out. And
I'll throw out one other thing real quick.
Sure.
Every Wednesday, our organization has a crime and ease in about half hour. Mine's going to start. Every Wednesday, our organization has an online Zoom meeting. We have usually 12 to 20 people that represent our staff as well as interested people that join in. We preset certain topics, and even within a non-preset topic meeting, we'll discuss different things. If you are interested in attending, interested in knowing what some of the agenda topics are so that you can pre-select what you'd like to drop in on, you've got my email address. Don't phone me. It's just not the most efficient way. Send me an email that you would like the Zoom link so that you can attend. And it's not necessarily a support group, but it's also a way. And if there's enough of you guys interested in dropping in, we can prearrange a particular Wednesday from 1 o'clock to 5 o'clock, or honestly, whenever we just run out of steam, to talk about a particular topic you're interested in. So, use that as kind of a start point for, a support entity. And we would be happy to consider issues and questions you bring up. So know that you're going to be Zooming. So know that you're going to either Zoom by your computer or you're going to do this by your telephone, and know that you're going to be talking about stuff in front of about 12 to 24 individuals on any given day. So more than happy to have you join us on our Wednesday afternoon soirees.
That sounds fantastic. And again, when I send out the slides, your email address will be on there. I put it in the chat group for people to reach out to you, but I can't thank you enough for giving us an extra half hour of your time. I know how busy you are, Bill.
No,
and
this helps, a person. We've done our job. We've
you have
better.
helped many, many people. And I just want to remind everyone that this will be recorded. It's been recorded and will be on our website by the end of the week. So, you'll be able to go back and check it out and just review everything that Bill went through. So thank you, Bill. Thank you all for your time. And we hope to see you next week at our webinar that we're doing on supported decision-making next Thursday at 10 a.m. So for information on that, please visit our website at achievafamilytrust.org. And there's information there and on the event, on the program, and how to register for it. So thanks again, Bill. And thanks everyone for staying on for so long.
Bye-bye, guys.
Bye-bye.